Are you a healthcare professional looking for a trusted concussion resource? Then you've come to the right place. From her New York City studios, welcome to Concussion Corner with your host, Dr. Jessica Schwartz.
And now, a word from our sponsor. Did you know that sport helmets are rated on a 5-star system similar to cars? And the safest helmets have nothing to do with price, brand, or availability? Since 2011, Virginia Tech researchers have been providing unbiased helmet ratings that allow consumers to make informed decisions when purchasing helmets. The helmet ratings are the culmination of over a decade of research identifying which helmets best reduce concussion risk. This work is done as part of Virginia Tech's service mission and is 100% independent of any funding or influence from helmet manufacturers. Our mission at Concussion Corner is to expose you, the listener, to trusted spaces in the concussion arena that translate to clinic next day. Please visit the Virginia Tech Helmet Lab website in our show notes or at bit.ly/Virginia Tech Helmets and spread the word to aid in lowering concussion risk in your community. Thank you for tuning in, and let's begin the show. Welcome to the Concussion Corner podcast. My name is Dr. Jessica Schwartz, and I'm thrilled to have Dr. Helena Esmonde back with us for part 2 of her podcast. Dr. Esmonde is a board-certified neurologic doctor of physical therapy and has been treating patients with dizziness, vertigo, and imbalance for 15 years and passed the Emory Vestibular Competency Exam in 2015. She became certified to treat cervicogenic dizziness in 2016 and achieved board-certified neurologic clinical specialist designation in 2018. Dr. Esmonde has taught continuing education courses on concussion, BPPV, balance assessment, and visual vertigo treatment, and serves as a teaching assistant at the University of the Sciences in Philadelphia. And she regularly presents at the Balance Center rounds at the Hospital of the University of Pennsylvania. Dr. Esmonde is also a co-founder of Vestibular First with her husband, Patrick Esmonde, a company that makes affordable FDA-cleared Insight infrared video goggles, as well as vestibular and education tools for rehabilitation professionals, educators, and students. Helena, welcome back to the Concussion Corner podcast.
Thank you. It's great to be on with you.
It's great to have you back, and we're gonna just hop right back into it. And what I would love to, just to summarize part 1, we'll have part 1 in the show notes for folks. And I actually want to, and I didn't do it last episode, I want to shout out Melissa B. She commented on our Instagram post. We're on Instagram, Facebook, Twitter, and she asked us actually to raise our audio levels. So from at the Rehab Lab on Instagram, Melissa B, if you're listening in Toronto, Ontario, we have raised our audio levels for you. So please give us feedback. When you guys give us feedback, I do my best. So hopefully our audio levels have raised for you these last 2 episodes. Okay, so, Helena, we were talking first episode, we were talking about the persistent patient and how you're often seeing patients with your skilled background as a board certified neurologic clinical specialist and a doctor of physical therapy. You have your, the gold standard in vestibular training from Emory and a slew of other continuing education postdoctorally for yourself. And then we ended up finished talking about, the use of objective tools and measures. And we were talking about the goggles and that you and your husband created this family-owned business, creating Vestibular First and these affordable infrared video goggles. So I would love to kind of continue with a little bit of the persistent patient conversation, and then we'll pick up on the goggles and why that they're so important in neurological rehabilitation and physical therapy, not just for physical therapy, and kind of take it from there. So in your clinical experience before you got into this entrepreneurial creator, awesome superhero world, I love it, all of it. What was your experience as a clinician using goggles and not using goggles, and how did you kind of entree into using them?
Yes. So you don't know what you're missing until you know what you're missing, right? So
let me tell you, well, I know I have actually said this to a vestibular therapist before, and I got a good cackle out of them. It's like eating, a fast food chain pizza and then coming to New York City and eating like a real slice of New York City pizza. So they said, that's exactly it. So
that is on point right there. Always love a good food analogy. So
Yes.
yes. So I worked in the hospital setting, examining vestibular patients on a regular basis, which we talked about a little bit last time. And I did not have goggles. So, I was certainly just trying to do what I had learned in the courses that I had taken and listening to the patient's symptoms and, trying to see what I could see in room light. And, doing a fair job, I think, as best as someone with moderate experience and no goggles could do. And when I went to the outpatient setting where they had a pair of goggles, I was basically blown away. And I was like, wow, like this is what's going on. And
Yep.
all these more subtle eye movements and realizing that although patient symptoms are important, they're not always as helpful as we would like them to be. And I think this goes back to the brain, which we talked about a bit last time as well, because sometimes you could put a patient into what we'll call a testing position and they will feel very little or no symptoms, but the eye movements I'm seeing are like very significant. So, I don't have to get into specific diagnostics. This is not a course, but I'll just say that can tell me something, okay, well, they're not feeling a lot of symptoms, but this is what I'm seeing. And does it fit this pattern or that pattern as far as what diagnosis we might be looking at here?
Well, let's just actually talk about this because a lot of folks may have never seen what you do, in this position with literally the patient's head in your hand. So, we're seeing, horizontal nystagmus. We're seeing, different types of movements with the eyes. What are you seeing? Maybe let's call it the top 3 things that you're seeing.
Sure.
As a neurological clinical specialist, doctor of physical therapy.
Right. So the one thing that kind of comes up in any basic vestibular course for a clinician is what they'll call central issues, which is something that's going on with the brain. Let's say a stroke, for example, that's affected a part of the brain such that we're getting abnormal eye movements because the tracts that are involved are parts that affect or are kind of ones that would be connected to the eyes and the ear, for example. Our inner ear balance system is our vestibular system. So, for example, I might put somebody in position and their eyes are beating downward. So this kind of vertical downward beat is typically considered what we call a central sign, meaning, well, there's something wrong with the brain, whether it's a stroke or MS, a concussion. You might have to figure that out through some various history taking or even imaging, MRI of the brain, that kind of thing. But at least you can say, okay, this looks central. And another thing you might be looking at is what we'll call peripheral causes. So one easy example is what we call BPPV. So that's benign paroxysmal positional vertigo. It's this kind of little tiny crystals that we all have in our inner ear that help us sense gravity. And sometimes they go into the wrong part of our inner ear and they create this kind of spinning, dizziness, off balance feeling. Could be many different sensations in reality. People call it spinning, but often the patient is not spinning and they will feel some other sensation, but that's what's going on. When I look at the eye movement, luckily with BPPV, there's very predictable patterns that we expect to see depending on which canal. And there are 3 in the little tiny sensor we have, and we have one on the left and one on the right, right? So we have these 2 sensors, 3 canals per sensor. Acting as almost like a little mini gyroscope. Okay, it's about half the size of a dime. So the crystals are literally microns in size. But depending on which canal they're in, it's going to give me a very characteristic eye movement. So for example, if they're in the horizontal canal on one side, we're going to see a horizontal beat. Whereas if in their posterior canal, we tend to get what we call torsion, which is kind of twisting motion of the eye. And it should be, for example, posterior should be kind of a torsional towards the side that's affected and up. So we're looking for these patterns of eye movements with these different pathologies. And of course, they can coexist. So someone could have some findings of a central nature because they've had a history of concussion, we'll say. And they could be having an episode of BPPV where we're also getting some of these patterns that fit, that crystals are out of place in, let's say, the left horizontal canal or something. So it takes definitely a trained specialist to kind of suss all that out, as I like to say, and kind of peel back the layers of the onion and say, okay, what makes the most sense here? And how do we proceed with a strategized treatment plan?
Do you guys ever see any, and this is just this is like a softball thing, but we have 3 canals. We have a horizontal, posterior, and a anterior, like lateral canal. Do you ever see any thing with that tertiary canal, any involvement there? And why do we not see involvement there?
Right. So that anterior canal or superior canal, depends on who you're talking to. Same thing. Because it goes up like the Arch of St. Louis, it's not really easy for crystals to make their way up, right? That's not gravity is not pulling up. So it's less common. I believe it does occur. I've seen it at probably a handful of times in my entire career. Unfortunately, this kind of straight up beat, which can be a possible BPPV, is also common with central conditions. So it can be a little tough to figure out for sure whether it's a central condition that you're dealing with when you see that upbeat, or whether like a true kind of more vertical upbeat, or whether it's anterior canal. So I usually look for a couple things with that. One would be a kind of a time-based approach, meaning I put you into my positional test. So I lay you back, put your head back, and turn to one side, or even in the middle is sometimes a way to test the anterior canal more specifically. It's called the deep head hang test. But either way, you're testing that kind of anterior canal. If you see kind of a crescendo of this kind of eye movement, this kind of it's a downbeat eye movement, and you see a crescendo of, oh, I feel some symptoms. Okay, that's that thing I was feeling when I was turning over in bed or whatever. And then it goes away, and the eye movement goes away at the same time they're saying they feel better. That is very much characteristic of BPPV. So that would lead me that direction. Now, if it doesn't behave that way and it's more of a constant beat, and if they are like, I feel nothing, that leads me towards central, because interestingly enough, the brain is more of an accommodative type thing. Like I said, it knows how to learn. So even though I see a lot of interesting eye movements in, say, someone with multiple sclerosis, for example, they don't always have a lot of symptoms, actually, because the brain is kind of accommodated to this dysfunction to an extent. Now, their balance is probably not great, but particularly with their eyes closed. But they may not have a lot of dizziness necessarily. So again, you're kind of looking for what fits the patterns as best you can, and then treat to that. And there's even been a recently proposed theory that sometimes what looks like anterior canal BPPV is actually posterior canal BPV, because the shape of the posterior canal, there's what they call a short arm, which is kind of the last portion of that canal. And sometimes when crystals are moving in that portion, it can kind of create this downbeat that looks like anterior canal. Luckily, both anterior canal BPV and short arm posterior canal BPV respond really well to the deep head hang treatment. So that's what I tend to use, and I've had great success with that in those cases.
And I want to talk about this actually, where I want to talk about timing. And again, an exercise, prescription and things like that. We talk about intensity and frequency and duration and the whole nine. And I want to talk about actually how slow this process is, because again, there's a reason why physical therapists, and I say this as firmly as possible, we need more time with our patients, right? So this is why we can't be doing these Medicare 8-minute treats and then bill for something, because we actually put our hands on our patients, and especially with neuro patients, we just need more time with them to recover. Now and on top of the the Insight infrared video goggles, you guys also created, it's super cool, and I'll put the link in the show notes. It's a fluid-filled vestibular apparatus, and it's an actual little 3D model with very cool viscous fluids inside and crystals that are color coded for each canal, posterior, anterior, horizontal. And it really helps for learning. But what's important too is that it seems like you kind of hit the nail on the head with, you didn't put this filled with water, you used some kind of viscous oily substance that really shows the time that it takes for these crystals to move. So I would love to kind of explain why you need the time to do this. These aren't just quick, an Epley maneuver is a quick movement, but that have to have the patient hang there for a while is important. So I'd love for you to comment on that.
Yeah, there definitely can be quick and slow components to treatment, and we'll talk about that here in a second. But so we were lucky enough to work with Dr. Timothy Hain out of Chicago, who is at the Chicago Dizziness and Balance Center, has a very comprehensive website for anybody who's getting into learning more about the vestibular system. And a lot of text, heavy reading, but very thorough and very evidence-based. So I appreciate that. And then Dominic Obrist, who's a researcher out of, I always mess this up. I think it's Switzerland, Sweden. It's either Switzerland or Sweden.
Blonde country. We are in those countries too. So we'll make sure.
Definitely. One of those. We can Google him and you'll be able to tell which one it is. Anyway, he's great. He's very receptive, and he's a fluid dynamics researcher who's looked at the vestibular apparatus and how it functions in real time. And so between the two of them, we were very careful to get the most accurate fall rate possible. And we did use mineral oil, and for the different colored stones, there's coral and malachite and turquoise. And we made sure that they were the right size to be proportionate to the size of the canal. And then we wanted that fall rate to be accurate, because it is true that when you're a clinician, and it's very important to understand that when you're doing these different maneuvers, there are these recommendations on time, 1 minute in this position or 2 minutes in this position. And the reason that they tend to be usually a longer time frame is because we're waiting for these crystals to slowly drift through this fluid and make their way to the next part of the canal until we can work them way all the way down to the end to drop into what we call the vestibule. So they can go back into the utricle and attach where they belong, or maybe dissolve in the fluid there, whatever, but get out of the canal. That's what we want to do. We're going to get them out of the canal. And if we rush through these maneuvers, and I've had patients, unfortunately, they're trying to do self maneuvers, which can be very successful, but if they don't quite understand the right positioning or the timing, they'll just be frustrated because they've created a feeling of symptoms because they're moving the crystals around, but they're not really getting them back where they belong. And so then they end up not always getting success. It is better if they've at least had guidance from a therapist first to kind of really get good, hopefully, at that maneuver if they feel like that's appropriate for them to do. But what's interesting is about 70% of the time, if you get BPPV, the next time you get it, if you do get it, not everybody gets it a second time, but about half of the population, once you've had BPV, you'll get it again. About 70% of the time, it'll be in a different canal or a different side. So the same maneuver is not necessarily going to work. So, it's tricky that way. Now, 30% of the time it could, so it's not zero, but you just have to kind of keep that in mind. And this is, again, why having someone who can properly, fully assess. I've had so many patients say, oh, yes, I saw this clinician and they did this particular test we call the Dix-Hallpike test, which tests for posterior canal, which granted is between 70 and 90% of the time of BPV, that's what it's going to be. But what about that 10 to 30% that it's not? You know what I mean? So you tested, oh, nope, it's nothing in the posterior canal, we're done. And it's like, well, no, you're not done. Not to mention the multiple canal cases, which definitely exist as well, and occasional bilateral. So
well, and definitely let's talk about that, because I think from a patient perspective, but also from a clinician's perspective, if they've never seen this, I will never forget this. I was in a major New York City hospital, and they have a fantastic vestibular program at the hospital, and I'll leave it unnamed, but I was a student, and there was more of a novice to moderate, but being guided by a senior clinician. And I will never forget, they put this patient's crystals that came up from the ED, it was an emergency visit, into the wrong canal. It was so evident, and you heard a scream and like you have never heard before. So, while that is super scary and it's memorable and it's a good learning perspective, and then as soon as that they went into that wrong canal, they were able to place the patient back into the proper canal, and then within literally minutes, they just immediately felt better. And the patient's hugging the therapist. This was like 20 years ago, but they're hugging the therapist, and this is pre-COVID when you can hug people to say thank you so much, and so on and so forth. This was a repeat offender. This is a patient that every few years would come in, and they had a relationship with the PT department in this hospital, and it was very interesting to see as a student learning, back in the day. But I would love for you to talk about that, the incidence of, more novice clinicians, or the fact if you do have multiple canals going on, as a patient in that moment, what that looks like and feels like, because it can be scary.
Yeah, no, that definitely, I think, this system is so powerful. It's designed to, give us information about minute head movements, right? So now you have these crystals in this canal, and as they shift in the canal, they're sending false information that this person literally might feel like they're falling over, spinning. I mean, it can be very intense sensations, for such a little guy, as I like to say, he can cause big problems. And so, it's I think, again, really critical, like you're saying, to be well trained, but then to accept that, what's really fun about the human body is that, again, there's so much individual anatomy variety. So
Mhm.
we know through some of the studies that have been done on the inner anatomy that, these canals are not perfectly smooth. First of all, they're kind of crookedy. And they can be angled kind of with some variation. So although we have maneuvers that are pretty well lined up, I've definitely had folks where the eye movements in a certain position didn't quite make sense. But then when I did maneuver in kind of that kind of alternate plane, it worked for them. And so that just tells me that probably their vestibular apparati, are just maybe set up a little differently. The way that I have little tiny crooked pinkies at the end, they affect my function not at all, but that's just the way my anatomy is designed. So, I think the more experience you become, again, the more you kind of recognize that you need to look for the subtle differences and kind of make adjustments. And it's not cookie cutter. I think that's what new clinicians, fair enough, struggle with. It's just kind of like, well, I know this one way, or I know, you know what I mean? Like, this is supposed to work. And it's like, supposed to doesn't happen. You know what I mean? Like, it's really, and then in the same way, just educating them, the patient, I'm much more comfortable with a clinician who says, this is what I know, and we don't know this yet. The literature's not there or whatever, than a clinician who says, oh, I can fix you no matter what. That's like a red flag to me.
Yeah, that's a dangerous clinician.
Dun, dun.
Yeah, we talked about, what I teach with in the first episode, you have to know what you're looking at, so you know what you're looking for. But then it also comes around, my other tagline is, and also besides, we need to validate the patient's symptom profile in front of us. But oh my God, I totally forgot what I was going to say. Wait a second. So what did you just say before that? I'm going to leave this in.
Oh, we're talking about clinicians who maybe overpromise.
Yes. So thank you so much. So the third thing, thank you so much, is that I say it all the time. And my patients trust me so much more for it. Especially even when I'm teaching, it's important to say the best thing that we can say to our patient when we don't know is, you know what, I don't know, but let me take the time to find out. Especially when, someone like yourself or me, they've seen, 5, 10, 15 providers before they come into, our door. So it's the most powerful thing to say to a patient, especially if they've been in this trajectory of like just patient, the rigmarole of they don't know how to be treated, or they've been misdiagnosed frequently. So just super important, as a senior clinician like yourself.
For sure. And it's funny because I've gotten to the point in my career where I do get these patients that have seen quite a few specialists and have had different clinicians, and they almost are fearful, which is totally understandable. They're like interviewing me. They're like, "Well, how would you approach this? And what what is your experience with this kind of patient?" Based off of their own past experiences. And so, I think the best thing we can do, whether I'm a new clinician, which I can remember being, or an experienced one, which I am now, is to say, I'm always willing to learn. I want what's best for you. I want to work with you. And I'm always willing to go the extra mile to try to help. And I think that really goes a long way, because again, it's so much more comforting to me to say, okay, this person isn't just kind of, like I said, over promising or kind of having some kind of magic, but also saying, well, this is what I know. And with BPPV, you come in my door, I am pretty sure we're going to be able to take care of this, just because the literature's there and I know that I've done that. So like that, I'm willing to kind of, that's what I call like where you feel like the magician for sure. And I joke that like those patients who's are willing to have their eyes recorded so I can show them this is what I'm seeing. And they're always like, whoa. Then they're like willing to sign the release that I can show like students and even, clinicians or whomever, because they're like, you helped me, whatever, like tell the world. I don't care if you show my eyes to anyone.
Exactly. Yeah. And they're also usually pretty unidentifiable. So it's pretty good.
It's true. I mean, technically the iris is considered uniquely identifiable, but I agree with you. In reality, it's not that identifiable. So it's good because it allows us to teach. I do, as you mentioned, a lot of teaching, and it's my dream not to keep people from learning because I think them as competition. And we talked about this offline, but because I want so many good clinicians out there. That's what I want. I want everyone to be empowered with the right tools and the right knowledge as best they can so that the more patients can get the help they need. That's my dream.
Yeah, and that's, it sounds like you're living the dream because you created something that can really help people in a very meaningful way, and it seems to be accessible, and that's so important in a time of inaccessibility, from whatever the reason being, third-party payers, not enough funding, just not enough time. There's just so many variables that affect the clinician or a patient's time with the provider. And just looking at the website vestibularfirst.com, again, the goggles are used in neurological rehabilitation, to look at both peripheral and central disorders. Again, central disorders like post-concussive syndrome, like vestibular migraine, like motion sensitivity, like visual vertigo, post-stroke, and other central, acquired brain injury disorders. And then we also have the peripheral disorders, which we've been talking about with the vestibular apparatus or apparati, looking at BPPV, and even other things like Meniere's disease and vestibular neuritis or labyrinthitis, acoustic neuromas, and other labyrinthine infarctions. So for you, we have another 6 to 7 minutes. I want to just talk about really that you went through a patent process. I just went through a trademark process, so it's traumatizing. So respect to you and Patrick, your husband. Hi.
We'll be in a support group together.
Exactly. Like you should look haggard. This is not like living in a COVID world.
It's a good thing we're on a podcast. They can't see our tired eyes.
I know. I always say, my mother says I have a face for radio. So, so good Lord. But yeah. So, I would love to talk about the, you went through the FDA approval process and why that was so important for you. On top of just being, 75 to 80+% more, I don't want to say cheaper because it's more affordable. It has nothing to do with the quality of your product. Why that was so important to you.
Yeah, so the patent certainly, from a practical perspective, is protective. But, what our patent is based on, because the patent is based on something unique, right? So what makes us different from the other technology, which I mentioned has been around since the 70s in various forms, is we chose to do what we call a modular design, which means there's pieces. So there's the strap. There's what we call the kind of durable cushion, and we're working on a disposable cushion for hospital settings. There's the kind of the body, which is kind of like the middle, and then there's the camera unit. And we did that design for two reasons. One is, again, affordability. So like if the strap breaks, which someday somebody's going to break a strap, that's just how things work. They don't have to buy a whole new unit. They could just buy a replacement strap. And I know that's been an issue with some other technology in the past. So I'm really happy to make that not a problem. And then the second idea is that we're going to develop these different, what we're calling add-ons, for lack of a better term. So instead of having the camera unit in place, that can be removed, and you could put on something that would record eye movements with what we call targets. So that's what we affectionately know as saccades, smooth pursuit, optokinetic nystagmus, these kind of like eye movement type tests. We're going to develop our own eye tracking software so that we can provide data to folks who need that. Not everybody does, but some really need it. So that's going to be a big project coming up. I'm going to be plenty busy forever. And I'm not going to develop that, by the way. That's going to be some person who knows a lot more about software than me, but I'll be I get to be the opinions leader. That's what they call me in the FDA paperwork.
That's awesome. I hope that's on your LinkedIn somewhere.
Like a legit title in the FDA paperwork. So we had a consultant who did a fantastic job. But on top of that, you can either pay a consultant to basically do that whole process, which there was like between 700 and 800 pages worth of material to be submitted to the FDA for clearance, or you can kind of do what we did, which is write a lot of it ourselves and then have them just kind of edit it and give feedback. And that's what we chose to do to save money, because again, we're trying to keep our costs low. So the less we spend on these things, the less we have to charge for our product, right? So I wrote a lot of that, and yeah, right. I mean, it's amazing what I always say this, like, if you're someone who's a clinician of any kind, probably you're a good learner. So like, okay, I didn't know about FDA, but I could read and learn and listen and absorb. And yeah, it was like a whole new world, and manufacturing is too, which I'm also learning about, whether I want to sometimes or not, because there's many challenges. And my engineers sometimes laugh at me because I'm like, can we just do this? And they're like, well, Helena, what about this practical aspect of physics? And I'm like, oh, shoot. Right. And then
science.
I know. Well, like the camera distance and how far it has to be from the eye, because I wanted it to be as close as possible. So there'd be more room for like face down positions. But we did as close as we could get and still have like focus and things. So that's kind of the trade-offs you have to make. Right. Cool. So kind of that patent process so that we could kind of have an expandable product, so to speak, that anybody who's like, ooh, I want an affordable VHIT. That's my dream, is also to create an affordable VHIT. VHIT is a really cool tool to look at if the peripheral vestibular system is working well, not about crystals, but more about kind of the apparatus itself or the nerve associated with it. So vestibular hypofunction, we would call that. So I think that's something that more clinicians should be able to access, but right now it's just quite expensive. So
awesome.
So I just have a lot of things that I want my engineers to do for me. We'll see what order we can do them in and how quickly we can grow. The more people that buy products, frankly, the more that we can do the next thing to help more people. That's always like what's pushing me. It's funny when I'm like in a demo to explain my product. I don't think I'm salesy because it's not my style. I'm just more like, here's the facts, ma'am. But like, but I obviously like have this innate enthusiasm. So like, I always feel like people are like, man, you're like just really into this idea. I'm like, yeah, sorry.
No, I mean,
but they usually
it's so
appreciate
cool.
it.
Yeah, no, it's so cool because you solved a problem. I mean, you solved a problem in terms of affordability. You solved a problem in terms of longevity of you have a product, and it would be so ridiculous to have a product that's, thousands of dollars or even $1,000 or even $20 and the strap breaks and you can't replace it. So the fact that you thought ahead of, in terms of, seems like most things that real clinicians go through. And listen, let's be honest. If you are and we have a lot of folks that own their own clinics and that they run everything and they understand how much things cost and how much they are to maintain, you tend to care for things with kid gloves. But when you don't have that, and it's like a child, like with, you just put down new wood floors and then you're like, okay, you take off your shoes and walk in your socks and, you're Swiffering every day. I just got new floors in 2018 after a crazy New York City asbestos thing that happened. And it's like, it's like one of these things, but, thank God for insurance, but then you realize just how much things cost, and it's like, okay, I even talked about like, do we get the dogs like socks? Because I was like, oh my God, don't scratch the floors. But my point being, after I digress, is that we want to make sure that, longevity. So there's going to be a student that comes in, there's going to be a new hire that doesn't understand what something costs. And something is inevitably going to break. That's going to happen. Things are going to drop. And the fact that you can replace the camera, it's actually brilliant that you're going to, not for the environment, but in this time of like pandemic time, that potentially have a replaceable cushion and things like that. You're just thinking in terms of real terms. So very cool to get to know you and learn about, Vestibular First and all that you guys can offer, and really where you guys are moving forward. So let's just leave, the listener with, and even we do have patients that tune in, let's circle back before we sign off the last minute or two here, of you have these persistent concussion patients that you're seeing in clinic. You're either using the goggles, not using the goggles with them, depending on, their patient presentation and what have you. What are you seeing in terms of outcomes of patients that you are treating with positive outcomes that have been years out? Either they have adapted to their new situation where they thought they were feeling hopeless or helpless, and then you have made a difference. What are some of those inspirational positive stories that we can leave our listeners off here with before we tune out?
Sure. I think three things come to mind. The first thing is, it's going to sound like I'm not really doing anything for these folks, but like proper referrals. And I've mentioned that earlier.
Absolutely.
And I have a patient who comes in with persistent migraine. That's another huge issue, right? Is this post-traumatic migraine presentation. They're waking with headaches, and they're long lasting. The ability for me to make headway with that group without continuing to try to kind of work with their, hopefully a specialist in neurology, maybe getting Botox injections. It depends on the person, what's right for them. But, that migraine management, and sometimes that includes them trying to test out, should they stop eating a certain food? It's unfortunately, it's very individualized with migraine. Sometimes what they're eating and drinking has zero impact, and we can try that out. And nope, it doesn't matter whether I eat this or don't eat that. And other people, it does have an impact. And so just being willing to go through that journey with them, even though, I'm not the main person in my head to be managing migraine, although I can think I can help. And then we know that aerobic exercise can help. We know that managing neck issues can help. So we do want to kind of put all those pieces in, but I don't think that I should be treating migraine alone. I'm really pretty firm on that. And I try to get my patients on board with that, because I feel like if they can find the right kind of neurologist typically, or sometimes a primary care who's really great with migraine, we can, make a lot more progress when we knock that stone down a bit.
Yes, and I'll put links in the show notes for the American Headache Society and American Migraine Foundation. For folks that they do have find a provider, and there are we'll definitely talk about that. We've had fellowship trained headache providers on, so absolutely.
Yes, and Shin Bei wrote an awesome book on vestibular migraine, which I highly recommend as well. Awesome. Dr. Shin Bei. Anyway, so yeah, there's a lot of good resources out there, but it's because it's so tough. So there's so many resources, I think. So that's one thing that I think immediately comes to my mind is if that's in the picture,
Proper
we gotta.
Referral.
Yes. And it can be ocular motor sometimes. So people who do need a neurooptometrist, and NOR is a great organization for finding one in your area. And sometimes they don't need anything, as it turns out, but I'd rather that get checked out, especially with these kind of more chronic situations, if that's never been assessed. I want that to be looked at. Sometimes they want to do vision therapy. Sometimes, again, there's nothing to be done per se. Other times they do need maybe a specialized lens. So I like that to be looked at. And also light sensitivity, which is related to this. Sometimes we have to kind of do adjustments, screens, special glasses. It's like you got to chip away kind of simultaneously, if you can, at kind of different areas. I talked about those different buckets earlier, and migraine and ocular motor are both big ones for a lot of folks after concussion.
Yes, and often underdiagnosed or not even looked at. So 100%.
Right. And I feel like people are like, oh, don't tell me about meditation and emotional stuff. But I'm like, but that's part of your brain. Like, so I do, sometimes it means having a formal psychologist or psychiatrist or counselor of some kind, to either manage with medications or with kind of what we'll call emotional support, kind of behavior therapy, anything like that. But there's literature behind these things. So it's not just me saying like, oh, you're just upset and you need somebody to talk to. Like, no, it's like, this is actually part of how our brain can heal. And so I think I'm remiss if I don't, that's, you can mention that multidisciplinary team. I think chronic concussion is probably more important, or certainly as important as your acute. So I'm always kind of pointing.
And I think that's so important to, we're going a little bit over time, so I'm just letting folks know to just buckle in for a second, but
sorry.
I think it's so important. No, it's good. I am the host. I'm just anything good.
You can do whatever you want.
Exactly. So, I think what Dr. Esmonde is saying is so important. And for you as the provider that's listening in, it's very, very important to understand and to connect with your patient. And this is as someone who is and was a patient living with persistent symptoms, is that, and treats concussion as well, is that you must build the rapport and say this to your patient in any which way, and you want to deliver this to them, but you understand that concussion and the concussive injury or the persistent symptoms that this patient is living with post-concussion is a threat to their I am. It is literally a threat to their self. So I am woman, I am wife, I am daughter, I am funny, I am a physical therapist. So it threatens all of those things that makes us who we are. So you have to identify with that, especially if the patient is more on the persistent side, but really anywhere from acute to chronic, symptomatology, and then make that referral. Because if not, that patient's just going to leave the room if you haven't built rapport, and it's a 5-minute, treatment session, and they're like, oh, this therapist is sending me to the psychologist. They think I'm crazy, or they say it's all in my head, which it's so important to connect to your patients in front of you, because that is where the medical legal literature has beat us to the punch. The medical legal literature has beat us to really the rehab literature, which is really on the cusp in the last 5 to 10 years. Again, 2017 was the first formal year we called this a rehabilitative injury internationally. 2012 was the first formal year we included the cervical spine in international conversations. So again, all of this stuff for us is new. Those of us that have been in the know, Mrs. Doubtfire, I used to be one, that have been in the know are aware of this. But to the lay public and to the medical world, this is all new. these are all new topics. And again, 8 to 10 years for things to hit clinical translation and knowledge translation. So, by you guys listening into these podcasts, you're already ahead of the game. So, yeah. And anyway, so that was proper referral and potentially, things like that. Anything else to
And they
finish
do
off
cover
here?
that in the clinical practice guidelines, which I do want to give a shout out to. The concussion clinical practice guidelines recently came out,
Yes.
and they're excellent. And they pretty much acknowledge how many areas in which we still are trying to grow the literature. And I think that's okay. That's just where we are. We got to be real. But also like kind of just calling out exercise was going to be the second thing I wanted to really push. There's no question that our folks need to be exercising. The question is how. Not everyone needs to be running marathons.
Correct.
Dosing. So I love marathons, don't get me wrong, but like not everyone should be running a marathon for various reasons, but one of them being it may not be appropriate because of concussion. So you need to think about, as a clinician, and I have started people literally laying down, contracting their quads and relaxing them. I don't care. Those are called quad sets. It's like, you got to start the process. And that's true because of the autonomic issues. This is true because of general deconditioning. This is true because, as I say, the brain needs blood flow. We know this, like the literature is very supportive, and it's just being able to grade it properly to not provoke symptoms more than you're helping with the blood flow. You know what I'm saying? So it's a fine line. You do have to, you've mentioned kid gloves a few times, and I think people sometimes, no pain, no gain, and this and that. It's ridiculous. That's ridiculous.
Not in this patient population. And this is where a do harm situation can happen, not because we may harm the patient but they will become a fear avoidant of the provider. And that happens all the time, especially with persistent folks that have, I call it doctor shopped, that they've either been mismanaged or they just didn't like and have a rapport with a provider. And then that becomes harmful, when someone has seen 10 to 15 folks before you. So, back to that EQ conversation of Daniel Goleman, you really have to know, your patient's trajectory before they've come into your door. So, anyway, so listen, we can talk all day. We're a little over time.
I know.
We'll definitely have you back on the podcast. And there's just so much we can talk about. Again, what's the best way for folks to reach out to you, to find you? We'll put everything in the show notes. Tell your mom that will make sure everything's spelled correctly.
So you can go find me on Twitter, Instagram, and Facebook at Vestibular First. You can go to our website, vestibularfirst.com, and you can email me directly at Helena, like the capital of Montana, but they say it wrong, like I said last time. And that's at vestibularfirst.com as well. And the parting word I want to say is make things fun as you can as a clinician. I am hands down, the brain does better when it's having fun. There is no question. So I am a game. I do so many games. I love games. Dual tasking is what they call it for cognitive challenge. Sure, call it what you want. I say make it fun. My patients do so much better when I make it fun. They don't notice their symptoms as much. It's just, it's really key. So please, clinicians, try to make it fun. I can give you a list of games if you want.
Yes. Please reach out to Dr. Esmonde. And again, what an important, ending note to end on there. And again, as vestibular therapists may be listening in, and you have all these certifications that Helena has, please connect to your job is to make your patient at some point during your session not feel well. So if you can make it fun and then reassure them that they are going to get better, and sometimes we overdose them and it's not intentional, it can be accidental, and it just may be because the patient in front of you has, had a rough day. I live in New York City, so the fact that a patient may have taken 2 trains, a bus, and had to cross Times Square to get to me, they should feel like, they've been through a neurological, assault on their system, because they have been. So again, depending on, making sure to meet your patients where they are, and, again, build that rapport, make it fun, and, really just awesome parting words, Helena. So, again, season 4 for us, we're, coming up on 70 episodes here. I'm asking for the first time, please consider rating us 5 stars on Apple Podcasts or anywhere that you listen to the podcast. It really means so much. Every podcast takes between 5 and 6 hours to produce and organize and do the whole thing. So, we're really all about bringing these to you, free open access foam ed, free open access medical education. And thank you guys so much for tuning in. And Helena, thanks so much for coming on Concussion Corner.
Thank you, Jessica. It's awesome.
Thank you for listening to the Concussion Corner, hosted by Dr. Jessica Schwartz. The information in this podcast is for entertainment purposes only and not to be used as personal medical advice. Don't forget to follow us on social media on Facebook, Instagram, Twitter, and YouTube at Concussion Corner.